edition of Thursday Musings. The most important topic everybody is discussing, everybody is talking about, everybody is concerned, many of them are giving lip service, and we have with us today one of the most eminent person in the country. We'll be introducing you later on. But first of all, I would like to introduce my co-host, is Dr. Aleem Siddiqui, and with us is our chairman, Dr. Tufan Pati. Pawan, can you give us a slide? Yeah, Professor Dr. Tufan Pati works with me. He's my head of department in the medical college. So a very senior man, one of the best administrators in the country. Then he was a national advisory board member of the IPP, was chairman of the membership subcommittee of the IPS currently, the life fellow of IOPM UK, he's organized ANSIPS twice, the vice chairman of IPP, president IPS East Zone in Odisha, the editor of the Industrial Psychiatry Journal of India currently, the chaired various IPS, IPP, ISP and AIP at different times, the life fellow, life member IPS, IMA, IPP, AIPA, IASP, Bhubaneswar Music Circle, avid Rotarian, numerous lectures, presentations, national and international psychiatric conferences, is the winner of Madhu Swabhiman and 4 Avenues of Service Awards. Over to Dr. Tufan, sir.
Thank you, Amrit. Thank you for your generous introduction. Maybe I don't deserve it. This evening, I welcome everybody, all the participants, those who are here and those who are going to come. This topic that we have chosen, suicide, is very much timely. In this post-COVID-19 area, the incidence of suicide is coming up. And anytime you get messages that I may commit suicide. Patients who are on depression and are suicidal are deprived of the medications. So in this background, we have this seminar. And first of all, it is my duty to introduce our moderators. Pawan, please share the slides of Amrit and Ali. And by the time he says, I shall be telling the importance of this topic. Many members have rang to me that this is the real problem they're facing. Dr. Amrit Joshi, he's a neuropsychiatrist, psychotherapist, and wellness consultant in Bhubaneswar. He's a professor and chief consultant neuropsychiatrist, High-Tech Medical College, Amri Hospital, and Healing Touch Clinic. He's a direct council member of IPS and editor of Odisha Journal of Psychiatry, which is indexed. He is the chief coordinator of UNICEF WHO IPS Initiative on Telemedicine and Psychosocial Management. Next, please. Pawan, next. And we have with us the dynamic Dr. Aleem Siddiqui. He hails from Lucknow, Nawab Ki Nagar, Nawab Aleem. He is the director of Healthy Minds Neuropsychiatry and Behavioral Sciences Center. He is a visiting professor of psychiatry, ERAS, Lucknow Medical College and Hospital, and Lucknow GSPM Medical College, Kanpur. He is direct council member 2. He is a guest faculty in Amity University. He is a finance secretary of IMA Lucknow and finance secretary of APPP, that is IAPP CUP and UK chapter. With this, I shall have a quick remark. Incidents of suicide is reported every day. Even we have come across reports about TikTok suicides. When TikTok was banned, 2 girls, they committed suicide. That was reported. I don't know how far it has been investigated, but the stress is that much. No money, no engagement, and stress is high. If a member of the family becomes COVID positive, or if there's a perceived danger of being COVID positive, the stress increases and people feel, I can't deal it. And they think, let me commit suicide. In this background, we have with us Dr. Lakshmi Vijay Kumar, and I would like to hand over the meeting for conduction to our chairpersons, Dr. Vivek Kirpekar and Dr. Yushigar, both of our very close friends. Slides, please. Pawan. Dr. Vivek Kirpekar, I have worked with him in CME subcommittee. He is a professor and head of the Department of Psychiatry, NKP Salve Institute of Medical Sciences and Research, Nagpur. Postgraduate teacher and guide, MUHS. He is past secretary and president of Indian Psychiatric Society, Western Zone Branch. He is the past chairman of the Election Commission of IPS. He is credited with e-voting in IPS that have started during his tenure. Convener of CME and Psychotherapy Subcommittee. He has been awarded Dr. L.P. Sauresan Award in 2019, and he has more than 35 publications. Welcome, Vivek. Welcome, dear friends. And next, we have Dr. Uttam Garg from Agra. Uttam Garg is from Agra, Shahjahan Ki Nagar, Agra. And he is a consultant psychiatrist for more than 33 years. He had been the past General Secretary of Indian Psychiatric Society and Indian Association of Biological Psychiatry. He is past president of IPS Central Zone. And he is currently the Secretary of WPS Section of Preventive Psychiatry. Welcome, Uttam. Welcome, chairpersons. Now the meeting is yours. Take over, please. Dr. Uttam and Dr. Vivek Kripekar, please unmute and take over the meeting. I am muting myself.
Thank you, Dr. Tufan Pati, for introducing me and my co-chair, Dr. Kripekar. Today's topic is very relevant because our country is going through a very concerned case of a very noted actor, Dr. Sushant Singh Rajput. So this term, suicide, is very much at the tongue of all the Indians. And during last decades, we have witnessed so many suicides of celebrities also. So the topic is very relevant, and moreover, the speaker is very eminent speaker, renowned psychiatrist. I request Dr. Kripekar.
Thank you, Dr. Uttam. As you rightly said, suicide is one of the very important topics nowadays. And world over, it is probably within the first 10 or 15 causes of death in young people as well as in middle-aged people. People not dying because of a natural cause. And we have a pleasure of having Dr. Lakshmi Vijay Kumara, the founder of Sneha, very well-known NGO in the fields of psychiatry and suicide. She is the head of the Department of Psychiatry, Voluntary Health Services, Adyar in Chennai. She is a member of WHO International Network of Suicide Research and Prevention. She is also an honorary associate professor in the University of Melbourne, Australia, and honorary adjunct professor at University of Griffith in Australia. She is probably one of the few Indians who have been conferred honorary fellowship of Royal College of Psychiatry, that is fellowship of Royal FRC Psych UK, for her work in suicide prevention. And she has also been conferred FRCP by University of Edinburgh in UK. She has also been awarded Ringel Service Award by Indian Association of Social Psychiatry in 2015. She has published widely in peer-reviewed journals and also has authored several chapters and edited 2 books. With this brief introduction, may I welcome Dr. Lakshmi Vijay Kumar to deliver her talk. Please, madam.
Thank you very much for the kind introduction. And thank you, Dr. Tufan, for this invitation. It's a privilege to speak to such stalwarts from all over India. And I will probably start my slide sharing if this is okay with the organizer.
Yes, madam.
Yeah. Just a minute. Can you, excuse me?
Yes.
Can I, you are sharing, so I cannot share. Can you stop sharing so that I can?
Now you can share,
Yes.
ma'am.
Madam,
You can, ma'am. Yeah, someone else was sharing. You can start now.
someone else has started sharing.
Yeah. Is it visible for everybody?
Yes,
Yes,
ma'am.
madam.
Fantastic.
Perfectly, ma'am. Yes,
Okay,
ma'am.
thank you very much.
Fantastic.
Thank you very much. So yes, this COVID has caused a lot of concern all over the world. A simple, most primitive organism which doesn't even have a DNA has changed our world upside down. So, but today I'm not going to talk about COVID and suicide, though we have started doing research on it. And we find that there are some changes which we are noticing in the suicide during the COVID lockdown time. We find that more employed men are dying by suicide than before. It used to be young women between the ages of 15 and 29. But now during the COVID, we are finding men who are between 30 and 40, people who are employed are dying more by suicide. But today's topic, my topic is assessment and management. So I will stick to that. So first, there is a lot of confusion about the nomenclature of suicide. See, when we are talking about suicidal ideation, we are very clear it is suicidal ideation. Or when we are talking of death by suicide, we know there is suicide. But in the attempted suicide category, there is a huge variety. Somebody who takes two crosins saying if she wants to die is also an attempted suicide. Somebody who hangs and is rescued is also attempted suicide. So there has been a lot of work on how to differentiate, because we need to know when to intervene and what to do for different types of attempts, for different types of suicidal things. And that is the reason why we need to have a reasonably common nomenclature so that we know we can prevent an attempt or suicide. So this has been more or less accepted now as a nomenclature to be followed. So at one end of the spectrum is what is known as a non-suicidal self-injurious behavior. That is NSSI, which has no intention of suicide at all. And then on the other end of the spectrum is suicidal self-injurious behavior. And in between, you have the big basket of undetermined self-injurious behavior, when you're not sure whether there was really an intention to die or there was no intention to die. And then when we come to suicidal self-injurious behavior, we have three, which is one is death by suicide, another is suicide attempt, and the third is other suicidal behavior. The other suicidal behavior is what we call as interrupted suicide. Supposing somebody is planning or doing and somebody else comes, then it becomes interrupted. Or if the person themselves, when they are doing something and then they decide to change, they come, we call it as an aborted suicide. So this is the nomenclature which we follow, and this is important for us because in terms of how to assess and in terms of how to prevent the act, it is important to have some sense of what this is about. So what is the basic elements of a suicidal scenario? If you look at it from the psychological perspective, there is intense psychological pain. In fact, Schneidman called it as psychache, like a headache, stomach ache. He said it's a psychache. It is intense psychological pain. And then there is a lot of self-denigration, which means they are not able to tolerate the pain, and the psychoanalysts usually call them as narcissistic self-injury. But the most cognitive aspect which you see in the person who is almost in imminent danger of dying by suicide is what Erwin Ringel, who started the International Association for Suicide Prevention, called the pre-suicide.
I think ma'am is not audible here.
Yes, some network issue.
Okay, we'll wait for a moment then to get her back in. Yeah, I think because of network issue, she's again re-logging in.
Yeah.
So we'll wait for a moment.
Alim, is Dr. Vijay Kumar logging in again?
Yes, sir.
Right.
We are calling her. We are calling her.
Okay, just call Dr. Tufan. Yeah.
She's just logging back in.
All right. See.
Hello.
Hello.
How are you?
Oh, she has joined. She has joined, I think.
Not yet, sir.
It's okay. We can wait for 1 minute. No problem.
Alim, if some of us shut off our video, maybe she'll get bandwidth to get into it.
No.
Maybe
So, sir, I think
Tufan
it is a
sir.
problem for her end. Yeah.
There
Her
is
end, is
no
it?
bandwidth issue at our end. I think probably the issue of network is at her end.
Okay, okay, okay.
Yeah.
So you can, our video does not affect her. So
Dume
All right,
sir,
all right.
Dume sir, good evening.
Ah.
How are you?
Good.
Hello.
All right, Uday.
आ जाए 1 or 2 minutes में mission भी join.
Okay, ठीक है. I am informing. Okay. Madam had rang. There are some net problem over there. She is joining again.
Okay.
okay, sir.
Dhumeji, good evening.
Good evening, sir. Good evening. Nice to see you.
How are you? बस कैसे हैं
I
आप?
am doing well, thank you, sir. I am doing well.
Thanks for being here.
Yeah.
And there's a request. Nobody should mark the screens. There are a lot of lines coming on the screen. So please.
Good evening.
Good evening, Gautam.
Good evening, Baba.
इतना देर क्यों किया?
आज लेट हो गया. इसके पहले एक मीटिंग था.
पेशेंट था?
नहीं पेशेंट नहीं. पहले एक वेबिनार था, डिबेट था, उसमें था.
अच्छा.
It is time that you have multiple screens.
तुम्हें जी कैसा है?
ठीक है गौतम दा, ठीक है.
अरे पवन थोड़ा धुमे जी को दिखाओ.
Sorry, I am back again.
Yeah, and Madam is back. Okay.
Sorry about this.
No issues, madam. No issues.
No issues, ma'am. Please
Internet
start
is
again.
pretty suddenly went off. So, shall I continue?
Yes, ma'am. Please.
Okay. So what we call as the triad of loneliness, helplessness, and hopelessness. And the most important feeling is what we call as aggression. It is not aggression, but aggression that is...
Can share the slides, please.
Oh, yeah, sorry. You're not able to see? Okay.
Start the slide share again, madam.
Are you able to see?
Yes, ma'am. Good enough.
Okay. 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 So a sense of aggression. Aggression is wanting to leave that place, you know, somehow escaping from that place. You know, that's what we call as aggression. So we know that people who have mental disorders are at a higher risk of suicide. Okay? They have a higher risk of suicide. But the fact is, people, let's say schizophrenia, it's a chronic condition. People are schizophrenic maybe for 20 years or 30 years. They are not at a higher risk right through for those 20 years. So it is important for us as psychiatrists to know when exactly the schizophrenic is at a higher risk, when exactly the people with mood disorder is at a higher risk, when exactly the alcoholic person is at a higher risk. So research has shown that early recovery, when a person who is schizophrenic, who recovers very early, is actually at a higher risk. Because what happens is when there is a very early recovery, people around them think that they are fine, they cope, and the medication, psychotherapy is not continued for a longer time as is required. So a person who has an early recovery has a high suicide rate. A person who has an early relapse also has a high suicide rate. So at times of early recovery, early relapse, we have to be careful. But the most important criteria is a schizophrenic who has a high level of achievement before the psychotic breakdown. People who have a higher IQ, held a higher position, and then faced this disintegration, they are not able to handle that. And those are the people who are at a higher risk. And people who are more agitated kind of a schizophrenic, they are at a higher risk. Agitation has always, poor agitation, poor medication, restlessness, and agitation always predicts suicide in the schizophrenic patients. And then what about bipolar disorders and depressive disorders? In bipolar, for a long time, we do not know whether it is unipolar who are more at die by suicide or whether it is bipolar. But we know that in bipolar, I think it is more or less equal. So there are enough studies to say that unipolar depressives have more suicides. There are enough, that is mainly because they spend more time in depressive episode. Whereas the problem with bipolar is that they are much more impulsive and so they are likely to have more suicide. So there are a lot of studies which favor both. But all the studies point out that a person in a mixed phase is at the highest risk. A person who has a mixed phase is maximum number of suicides happen during the mixed phase of a mood disorder. Then alcohol increases. And again, when does alcoholism is also a long-standing problem. So when does it actually, when do they actually die by suicides? It is not in the early phase of alcoholism, nor in the late phase of alcoholism. Usually between 8 to 10 years of alcohol use disorder is when their risk is high. And definitely what has been shown is if an alcoholic has an interpersonal loss, let's say a fight with a wife who leaves or a family leaving him, within 6 weeks, majority of them attempt or die by suicide. So an alcoholic who has been an alcoholic for about 8-10 years and there is a family conflict and wife leaves or something, then in the last 6 weeks, then the person is at a higher risk. Then of course we have borderline personality disorders. We know that the suicide attempts is much heavier, much more there. But it is much more in those borderlines who are impulsive and aggressive, and actually less in borderlines who have dissociative symptoms and paranoid symptoms. So what are some of the characteristics of a suicidal patient? Majority of them have difficulty in interpersonal relationships. They have interpersonal skill deficit. Majority of them have emotional regulation problems. They will not be able to communicate either their pain or joy in an appropriate manner. They can provoke, make us feel desperate and make us feel helpless. And most of them are ambivalent. So these are, I'm sure we all know, I don't want to go too much detail into this, but these are all the verbal warning signs. You know, what we need to understand is 80% of people who are suicidal do communicate their suicidal thoughts. Suicide is almost always never a surprise. It is most often they are not heard, or even if they are not heard, proper listening is not done, proper advice is not given, proper referral is not done. So one of the main reasons we can prevent a suicide is majority of them communicate to us. And then these are all the behavioral warning signs which we need to be aware of. I think most of us know about this, and but of late, particularly during the corona time, what I have found is people suddenly taking LIC policies for corona and life policy and all that, and taking huge policies. I found that 2 of the patients were having suicidal thoughts, and so they have taken this policies. And then amongst the psychiatric symptoms, command hallucinations do play a role in suicide, particularly people with psychotic depression, with persecutory delusions. They have a high suicide risk, okay? And people who are generally considered to be unstable, impulsive, aggressive, and all that. But of late, we are definitely seeing that panic disorders with agitation has been found to be associated with suicide. But the single most symptom which is common amongst all people who are suicidal is the most of them have insomnia, global insomnia. And that the peak worsens between 2 and 3 o'clock in the morning, just when the depression awakening also happens. So what about the mind of the person who is suicidal? Because we need to understand the mind of the person before we can assess and predict. First is, as I said, it is an impulsive phenomenon, okay? Even if people plan about it for a long time, the moment they decide to do it is a very impulsive phenomenon. And the third thing is, it is an ambivalent phenomenon. Most of them, the wish to live and the wish to die is like a seesaw battle for them. I'm sure when you have talked to your patients, most of them would say, it's not that I really want to die, but I just cannot go on living like this. And then they have recurrent suicidal thought. And it is a kind of a rumination. How do I say this? It's like, for example, a lot of times we have some music or some jingle which goes on in our brain, and for no reason at all, the jingle comes around. Like that, for them, it just goes on like an obsessive thought, you know, like really an obsessive, and that's where the perfectionism and rumination combines. And as I told you, the rigidity, the final say 2 weeks of suicidal build-up is an extreme rigidity, constriction of behavior, thought, cognition, everything. And that we call it as a tunnel vision. So when should we do a risk assessment? When we don't find any improvement with our treatment, and the time of high risk, when, for example, many of the suicides in people who have mental disorders happens just 1 month after discharge from the hospital. Okay? So 60% of suicides have, if the person has been admitted in a psychiatric hospital, 60% of the suicide happens within the first month after discharge. Okay, so we have to be extremely careful when we are discharging a patient from a psychiatric hospital, because that is the highest type of risk. And then interpersonal, in times of interpersonal loss and shame-inducing situations is more particular for young people. For young people, the biggest risk factor is anything which induces shame. It can be failing in exams, it can be girlfriend, boyfriend leaving you, it can be caught copying, it can be anything which produces shame, or being asked to bring the parents home for some misdemeanor or any legal action. So anything which induces shame is the biggest risk factor for a young people. Okay. So how do we assess? So first we have to assess the clinical state. How much is the psychological pain? And these are all, I'm sure, something which you all know, so I don't want to go too much into the aspects of it. But these are something which we need to also see. For example, if you have a child below the age of 18, the suicide risk comes down. The sense of responsibility for the children is there, so the suicide risk comes down. And if you have, even if you have all the negative risk factors, if you have a significant person who is very supportive of you, then the suicide risk comes down. Okay. And then the most important thing is many of the suicidal people reject the help even if it is offered. We call it as malignant alienation. Somehow they will make people who care for them, who love them also, so desperate and drive them up the wall, you know. So whether they are that type of a person or they are willing to accept help is another important factor. And of course, access to lethal means and reason interpersonal loss are some of the risk factors. Now, one of the first suicide prevention strategy is to ask the person whether the person is suicidal. As psychiatrists, we know the importance of asking suicide, but I must be honest and say there has been research from a leading psychiatric hospitals in the country where routinely whether the person is suicidal or not is being asked for in patients. Okay, it is left to the discretion of the postgraduate or the things, and it is not a routine matter to ask all psychiatric inpatients whether they have any suicidal thoughts. Only about 30% are asked. Now, everyone in the field knows that asking the person whether the person has suicidal thoughts or not is the first step towards prevention. So in fact, 3 years ago when we had the National Suicide Prevention Day, we said just ask, because that itself can prevent about it. And you can have various strategies of how you ask. So I always tell all the trainees, it is not whether to ask, but how to ask and when to ask. And you don't need to have a long list of questions to ask. You know, this 5-question assessment is enough for us to let us know about whether the person in front of us has suicidal thoughts, and if so, how serious it is. So if you look at it from the journey from the idea to act, first, it is an impossible problem. They feel that there is no solution to that. And then they think that suicide is a solution. Then it is a passive solution. Maybe I should die. And then it becomes active. And then when it becomes active, they start ruminating about how should I do it? Is it available? Ego syntonic is it comfortable with my image of myself? And should I do it alone? Should I do it in front of people? And then there is some kind of a preparation, saying bye, tidying up. And then they secure the means. Then actually many of them practice with the means before they actually do it. And then for example, if they are cutting, they want to feel the pain, they cut a little bit, then they make a non-fatal attempt, and then they make an attempt. But every suicide does not follow this journey. You can jump from 1 to 10, you can jump from 2 to 9, you can jump anywhere. In fact, people who die by suicide, 25% of them, it is their first attempt. Okay? But it gives a sense of how the person's thinking goes. So we talked about non-suicidal self-injury, which is what we find, in young people between the age of 10 and 14. It's lots of cuts. We think they have borderline personality issues and things like that. Now, the difference between suicide attempt and non-suicidal self-injury is that in non-suicidal injury, there is no real intention to die. It is relief from unpleasant effect. And the idea is, not to die, but to escape from the tension. In fact, for some of the famous cutters, they will say, doctor, I am cutting myself so that I don't attempt suicide. It's a relief of stresses for them. So the core problem there is body alienation and, relief from an unpleasant effect rather than intention to die. So when we talk about next, when a person says, yes, the person is suicidal, then we talk about what kind of plans, what is the lethal level of the plan, whether you have access to the means or method. For example, I can tell you, I'm so desperate with life, I'm going to shoot myself. But what is the point of saying that if I don't even know how to shoot or hold a gun? So whether you have the lethality of the plan, or if I say, yes, I'm going to kill myself today, I'm going to take 4 paracetamols, then you know where the risk is. So we have to know the lethality of the plan, whether they have the access to the method, whether they have fixed a time and place, whether they have made final arrangements. These are all the elements of a suicidal plan. And as I told you, 1/3 of them, see, it's like this. If you take 100 people who have attempted suicide and follow them up for 10 years, only 10 would die by suicide. That is, the asymptote is 10. But majority of the suicides happen within the first 18 months. About 60% happens in the first 18 months. And after that, it actually reduces. So in the essence, out of 100 people who attempt suicide, only 10 to 12 would end their lives by suicide. But whereas if you take people who have died by suicide, 30 to 40% of them would have made a previous suicide attempt. So it is important for us to know what kind of suicide attempt the previous attempt was to define how serious the attempt is now. So what was the precipitant? If it is a similar kind of precipitant, then the risk is high. What was the nature of the attempt? Did they really want to die, or what did they actually do is important, because it shows us how much they are prepared to do. And then the outcome. What was the associated injury? Was it medically serious? Did you do the attempt and then tell people, or did you not tell anybody and you were rescued? Because then the seriousness goes. If you made an attempt and then told people, then you are still ambivalent. But if you made an attempt and somebody else rescued, then the risk is high. Okay. And then most importantly, what was the reaction to surviving the event? Surviving it. Okay. You think it was not enough, so you want to escalate, or did you learn anything helpful? I did it, I'll never do it again. That kind of thing will help us. So to have more details about the previous suicide attempt is extremely important for us to assess the suicide risk current. Okay, now first, the other thing which we need to know are that the suicidal states are time limited. The intention to die comes and goes, and ambivalence is, I already talked about it. See, suicide is a very, very strong emotion, and we cannot be acutely suicidal for 6 months. You know, it is too strong for our body to take. What we have found is that a person is acutely suicidal for maybe 2 to 3 weeks. And those 2 3 weeks, if support is given, suicides can be prevented. Or if in those 2 3 weeks there is no support and there is an exacerbation of issues, psychological conditions and environmental conditions, suicide can happen. So those 2 3 weeks are crucial. And then again, it takes time for people to build up to the suicidal effect. So suicidal states are time limited, okay? But for people who are at chronic risk, you don't need an external stressor. For people who are not at chronic risk, you need an external stressor. So if we have to look and assess whether the person has low, medium or high risk, first we look at the plan, whether they have a plan, specific plan or a vague plan, whether they have the method and whether they have decided on the time, whether they have it with them, whether intervention is possible. These determine whether the person has low, medium or high risk. And same way, what about the previous attempt? Was it a low lethal or highly lethal attempt? Whether help is available and what kind of stress they have to face. This determines whether the person has low, medium or high risk. And what are the kind of symptoms? Whether they have coping mechanism. Well, what is the stage of depression? How impulsive they are? Is the communication direct or is it a very indirect method, a non-verbal kind of a communication? And what about their lifestyle? Is it a stable or a very unstable? So these all factors determine whether the person has low, medium or high risk of suicide. So this is a kind of algorithm for triaging the risk. So it comes to low risk, moderate risk, imminent risk and high risk. And if we follow this algorithm, we more or less will know where the patient is. Now, because just as I told you, because that it doesn't mean that one person cannot move from low risk to high risk, or a person cannot move from high risk to low risk or no risk. It is very, very fluctuation. So now this is the current thing for the last 2-3 years. We are all talking that we should change this mode of low, medium and high risk and look at it from a preventive aspect. And so we say we will have a risk formulation instead of a risk assessment. We will have a risk formulation and see, and this is currently being practiced in about 6 or 7 centers and we are still studying it. And it basically looks on risk state and status. Risk status is in relation to other people. For example, in relation to somebody who has no depressive history, somebody who has no previous attempt, somebody who has no family history. A person who has all this, the risk status is higher. And for that person, the risk status, when compared to sometime before to now, how I am. See, I may have family history, I may have depressive episode, but today I am feeling much better than what I was feeling 1 month back. So my risk state is that. So this risk, and the same way, the risk status, you have strengths and protective factors, long-term risk factors, and then you have what we call as that is more enduring. For example, you can't change your genes, you can't change the fact that you have illness and all that. Then you have more dynamic factors, you know, precipitants, stressors, support and all that. And then this risk status and state combine, and then you go to available resources, both internally in terms of yourself, maybe your religious beliefs, maybe your support system, maybe a good friend, plus the social support, or you may have a good psychiatrist. So all these are available resources. And then it interacts with the foreseeable change. What could trigger the person? So this is what we are thinking of now. It is not widely into practice, but this gives us more flexibility and opportunity to think in terms of prevention rather than assessment. Now I'll come to how we manage a suicidal patient. See, the biggest challenge in managing a suicidal patient is it's not a diagnosis, but a behavior. Unlike any other behavior, it is difficult to manage. Like even we know how it is. If it is even alcohol use disorders or something like that, when it is a behavior, it becomes difficult. The second challenge is when a patient in front of us says the person is suicidal, feeling suicidal, then we have a heightened sense of responsibility. And that heightened sense of responsibility and the fact that we are not able to control what the other person may do makes us feel stressful. Okay? And the third thing is the fluctuations in suicidality, which I already talked about. So what is the goal in crisis management? First is we must ensure safety. First, we have to ensure safety, protect the patient from self-harm, and we have to be proactive. We have to get support from family, social support, identify the underlying disorder, and we must act like a crisis resolution team. And the first thing we should do is to remove the means. For example, if they have a bottle of pesticide or a bottle of pills, just talk to them, coax them, and get those from them. And also safety planning is extremely important. I'm sure most of you have heard about safety planning. It is a very proven to be very effective in emergency care settings also. And let's see, I think I'm going, how am I for time, Dr.
Madam, no problem, madam. Madam, no problem.
Okay.
You can carry on.
You can carry on, everyone is intent.
Okay.
I think
some
the link is a week, yeah.
Some audio problem from Man's side.
I think the net connection is a bit weak again.
She is sharing the screen again, Adil.
I think she has to join back again.
Got disconnected, yeah.
Yeah, she'll join back again. Yeah.
Somebody's mic is on, and there's a lot of crosstalk happening.
पवन, सबका माइक ऑफ कर दो, जिसको कहना है वो खुलेगा अपना.
Yes, sir. I've kept
बीच में से करो.
Yeah.
Yeah.
In between, please mute everybody and let the speaker only unmute. So
Gautam, you are here?
If madam wants to continue, because the interventions are the most important part. So
Yeah.
let us not constrain her with time and all, because she already lost 5 or 7 minutes due to poor network.
Yeah.
So if possible, let her continue.
It's quite possible, because from the outset she's speaking on the interventions only.
Yeah, very good.
Yeah, I think, sir, as much time as possible she can take. Because there is a...
We have all the time.
तार लाइन पड़ोची.
I'm sorry again.
Oh, yeah.
The line is really bad.
Okay, okay.
No issues, madam. The quality is too good.
Okay. Okay, so I'm sharing the screen now. Are you able to see?
Yeah, yeah. Yes, please go on.
So these are the basic components of a safety plan. Okay, it is individualized, and we give the warning signs. What are the internal coping strategies without contacting anybody? Using other people as a means of distraction, then contacting family, friends, contacting mental health professionals, and reducing lethal means. So this is how a safety card, planning card looks like, okay? And it has specific numbers. So if for example, I can say, when I have these symptoms, I will listen to this music. If I'm not able to get better, then I will call my friend Anusha, like that, you know. So it is very specific. You have the card, and whenever you feel upset, you just look at the card and do the steps. And this has been found to be extremely useful. Okay. Okay. The protocol is the focus on the present, problem solve the current problem. Okay. Another thing which I want to say is, most of the people who are acutely suicidal would have skipped their food. They would not have had anything to eat. They would be so wrapped up in their thinking. Just making sure that they eat something for the first 15 minutes reduces the risk by 15-20%. Okay, so problem solve the current situation. Commit to a plan of action. We have to say, okay, we are going to do this. And then say, okay, what are the problems in this plan? Can we address that? Okay. So this is how we handle a crisis protocol. Now I'll come to the treatment part of it. This is a longitudinal study where they found whether cognitive behavior therapy helped a person who is suicidal. And you can see that in the first 6 months, there is definitely an improvement, and suicide risk is less if a person who is suicidal undergoes cognitive behavior therapy. But then at 12 months, the effect is less. And at the end of follow-up, it is really not effective. So CBT is useful in the first 6 months. So people are now saying that after the initial phase of CBT, like a booster dose, suicidal people need to have sessions. Then we come to drugs. Lithium has been the most beneficial in terms of reducing suicide for people with bipolar disorder. And most importantly, enough research has come now that even in MDD, in major depressive disorder, MDD person who has attempted suicide, low dose lithium helps prevent suicide. So it's not, lithium is not only for bipolar disorders. Even MDD who have had a suicide attempt, lithium has been found to reduce suicidal behavior. So in fact, there was a head-to-head comparison between lithium and valproate with almost 50,000 patients of bipolar disorder, and lithium, there is no decrease with valproate, but almost, I'm sorry, it is not 14%, but 24% decrease in suicide during lithium treatment. And now what about antidepressants? Are antidepressants effective? Again, here you can see, apart from sertraline, this is a meta-analysis. Apart from sertraline, all other antidepressants do reduce suicides. Okay, and this is for suicide attempts. And you can see for suicide attempts, none of the antidepressants. This is without paroxetine, and this is with paroxetine. None of the for suicidal attempt, antidepressants do not have a long-term effect in reducing further suicide attempts, and nor does it help in suicidal thoughts, but definitely it reduces suicides. Then clozapine has been found to be extremely useful in reducing suicidal risk in schizophrenics. We used to read that about 10% of people with schizophrenia die by suicide. Now, actually, after the introduction of clozapine, the number of schizophrenics who die by suicide, the relative, it has been found to be between 6 and 7% only die. So clozapine has a very effective, and in fact, some research is going on now, whether very, very low dose of clozapine would help in other conditions also to reduce suicide risk. But research is going on. We do not have the results. Now, of course, all of us know about ketamine. Ketamine is now recommended for resistant depression and particularly useful in reducing acute suicidal. See, when a person who is acutely suicidal, we want to reduce the suicide risk in the next 1 or 2 days, those who are in imminent danger. And for that, ketamine has been found to be quite useful. And this is an open label study where they assess the suicide risk. And there seems to be how many doses? They say that majority of the time in the first 3 doses itself, you are able to find an improvement. And if you're not able to find an improvement in the 4th or the 5th dose, then they are unlikely to be benefited. There's no point in continuing after that. So ketamine appears to have beneficial effects. It may be short term, but there have been recently 2 studies which have found an effect even after 30 days, okay? And particularly with S-ketamine and intranasal S-ketamine has been found to be extremely useful for an acute risk. RTMS has also been found to be effective because it reduces, I'm not a neurobiologist, so it is borrowed from a friend who has done this study in Belgium. So I don't want to explain something which I do not know much, but he says this proves that RTMS has an effect on hopelessness. So how do we clinically manage a suicidal patient? So we have to get the background information. We have to find the presenting symptoms. We have to make a risk assessment. We have to see the level of functioning. We have to see comorbid conditions because majority, 60% of people who die by suicide have comorbid conditions. We have to think about the stressors, the treatment received, past thing, find out the strength, summary risk, outcomes, and then possible barriers. Thank you very much. I just want to say that Steinman has a cure, and I will just try to show the, he has a cure where he says the person at the most highest level is somebody who has the highest level of environmental stress, highest level of psychological pain, and highest level of anxiety and agitation. So if you are able to move the person even by one single cue, that is reduce the psychological, even if you are not able to do anything about the environmental stressors, if you are able to reduce the agitation, anxiety, restlessness, or reduce the psychological pain, then a lot of suicides can be prevented. Again, I'm really sorry for the bad internet connection. Thank you for bearing with me.
Thank you very much, madam, for giving your views on suicide, management of suicide and diagnosing. It was really a very exhaustive lecture and a very clear cut.
Thank you. Thank you.
Between suicidal and non-suicidal intentions. There are so many things we are getting in our clinical practice. And sometimes...
Sir, it is not audible sometimes.
Am I audible? Hello.
Hello, am I audible?
Yes, sir, you are audible.
Yes, sir, you are.
Audible.
Acha, Alim, you are there?
Yes, sir. Can I request
Audible.
Shukla sir? Yes, sir. Can I request Shukla sir to moderate for now?
I'm here. I'm here. I'm here.
Yeah, yes.
Shukla
Salim
sir,
sir,
please.
I'm here.
Shukla, you have got the questions?
So I'm taking down the questions. The first question that was asked is, how do you manage a suicidal patient who lives alone and who doesn't agree to take your advice or the therapy you recommend? That is a question. This is the first question I've noted down.
Yes, a person who lives alone is always very difficult to handle. So the first thing we have to say is, however a person lives alone, there will always be somebody with whom the person communicates. Okay, they may not be physically there, but there may be somebody whom they have. In all our experience, we have found that they will say, I hate my mother, I hate my father, my family is not all right, nobody is there, but my uncle in the village understands, you know, that's what they'll say. So you can't bring the uncle from the village suddenly. But what we can do is, okay, if that is the case, can you give me the phone number of the uncle? I will ask the uncle to talk to you. You know, that is number one. That's the first thing which we have to do. So somehow we have to provide some connection. See, in all the suicide prevention research, what has been found is that some connection, if you are able to have, some contact you have. For example, this is called brief intervention and contact. We had about 2,000 people who have attempted suicide in 5 different continents of the world. And the intervention group, the only intervention was, in the next 18 months, they were contacted 9 times by the psychologist or even a lay person, either in person or phone, for 5-10 minutes. How are you? What are you doing? Okay. At the end of 18 months, those who had been contacted had significantly less suicide than those who have not been contacted. Forget about even phone. In Australia and Iran, what they did was, for all the people who have attempted suicide, they sent postcards, just generic postcards. Hope you are keeping well. If you're not feeling all right, please contact us. So 9 postcards were sent over a period of 24 years. Greg Carter from New South Wales and Resnian from Iran did this study. Those people who received the postcard had less number of repeat attempts on suicide. So all these people, as I told you, the fundamental feeling is loneliness. So if you are able to connect the person with somebody, some individual, some organization, something, then we have a good chance of preventing suicide. So providing some connection for a suicidal person should be our priority, particularly for people who are lonely.
Thank you, madam. Thank you, madam, for the answer. Madam, there is another question from Dr. Bharati Chala.
Yeah.
Her question is, there are many bipolar mood disorder patients who immediately after remission of the manic episode go into a depressive episode. So how to manage those patients? Should we start antidepressants or should we try to stabilize the mood only with mood stabilizer?
The first thing is, particularly if they are rapidly going into depressive episode, they probably are in the mixed phase. And in that phase, it is better not to give an antidepressant because they are likely to go into a manic phase again. So mood stabilizers, excuse me, mood stabilizers are the best method to continue. Of late, there is some emergent condition that adding a little bit low dose quetiapine helps a little bit. Now people are now talking about lorazepam also.
Okay. Thank you for the answer. Madam, there is another question. Her question is interesting. She is asking whether we can classify suicides. Can we classify suicides into 2 groups, like there are some preventable suicides and suicides we cannot prevent? non-preventable suicide, to put it in a way?
Yeah, it's an interesting question. The fact is, many a time when we think about suicide, we think it is due to the individual. So what can I do to prevent? Or we think it is due to some social factors like poverty, unemployment. What can I do to prevent? How can I change that? So we think we cannot prevent suicide. I would say that not all suicides are preventable, but majority of the suicides are preventable. Or rather, I would say, for looking at suicide as a solution, there are other possibilities. There are various other possibilities to solve the problem or the situation rather than suicide. So, how does one decide which suicide is preventable, which suicide is not preventable? We will not be able to know, because we will think that this person's suicide is not preventable, but that person will survive. I'm sure we come across many situations like that. We think, okay, this person has all the protective factors, they will not do anything, they will go and do. Okay. The main thing we cannot answer this question is because of the fluctuations of suicidality. So we have to make a decision based on that movement. So they cannot be categorized because of fluctuations.
There was a question from Dr. Watway. 1 minute. Our past president, Dr. Watway. थोड़ा उनको अनम्यूट कर दो पवन, वो डायरेक्ट पूछ लेंगे. Dr. Watway, please. You had a question on screen, I saw. Pavan, are you hearing? Please unmute Dr. Watway and bring him on screen. He can ask his question. Dr.
Yes,
Watway, please.
Sir is unmuted.
उनका स्क्रीन में जो yes, what पे सर पूछिए आप.
I had a small question about the. You can please throw some light on the suicidal behavior in children and adolescents, and are there any special methods of assessing and treating them?
Children and adolescents are always tricky because they do not have a specific depressive symptoms. But the most important things which we have to think of is their change in their personality, okay? Change in their behavior. Somebody who will not cut the hair, suddenly cut the hair. Somebody who will wear only jeans starts wearing formals, you know. A definite change in behavior is a very important symptom in children and adolescents. And the most important emotion which they would exhibit is irritability. Not definitely depression or crying, but just irritability, anger outbursts, irritability, temper tantrums. Those are all the symptoms which will come. And most of them will not be communicative with their parents. Most of the suicidal thoughts of the youngsters nowadays, they share with their peers or they share it in the social networking site, which the parents don't have an access to. So it becomes more difficult for the elders to intervene at that time. Because unfortunately, majority of the peers think that this is said something in confidential, I have to keep it confidential, and they don't tell the other people that this child is going through or this youngster.
Thank you.
You are here.
What was sir? Do you have a follow-up question?
Sir, ma'am, how much does it cost? How much does it cost to prevent a suicide? Any estimate on that? How much is the input required? What are the infrastructure, the helplines, the manpower? So actually, how much would it cost to prevent a suicide?
I think Madam is dealing now. Madam is dealing.
Not online.
Madam is, I think, again logging back in.
Again, net problem. She is logging now. Alim, you are here?
Yes, sir.
गए नहीं?
अलीम सर आप हैं तो?
Sir, I am switching in between.
और वो बीच-बीच में आते रहेंगे सर.
दो स्क्रीन है क्या? Alim, दो स्क्रीन है क्या?
Yes, sir.
Okay,
Multitasking.
very good.
Sir, Tufan sir?
Yeah.
Tufan sir, can we let our senior colleagues, senior secretaries unmute themselves and ask the question if they have any directly to
or if
madam?
they want to contribute,
Yes, yes.
their experience.
Any comments?
Anukant, you are here? Anukant? Anukant is not there. I think he has left.
He's not here.
If you are here, you can contribute. Abir, Dr. Abir Mukherjee. Abir was there. I've seen him.
He's there, sir. He's there. I think.
So, Dr. Abir Mukherjee, your input, please. Abir Mukherjee, am I audible?
Sorry again. Are you able to hear me?
Yeah, again,
yes,
please.
Very clear.
So
I had a question. Yeah,
we had
please.
the black box warning for paroxetine. So they compared the adolescent suicide rates in the US before the black box warning and after the black box warning. And they feel that after the black box warning, when antidepressants were stopped to young adolescents, the suicide rate in young adolescents are increasing now in the US. We have similar kind of a study from Hungary where they say that when adolescents were prescribed fluoxetine, the suicide rate was lesser. So these are if at all we have to prescribe an antidepressant to a young person below the age of 15, 16, whatever evidence we have now suggests to better efficacy with fluoxetine than with other drugs.
Thank you, madam.
Yeah, ma'am, we were just talking. How much does it cost to prevent a suicide? That means the amount of input, the manpower, the resources, the helplines. How much would it cost to prevent a suicide?
We actually tried to, when we wrote the World Suicide Report in 2014 for the first time in WHO, we tried to do a cost-effective analysis, okay, in terms of finding out what is the, to answer the question in a different way, how many lives will be, in terms of tallies, how much would it be? And we found that it was very difficult to do it, okay, because how do you put a value on the life? Because if you compare the GDP in an African nation to US, then it becomes very confusing, and we decided not to do that. Because I think as human beings, when it comes to saving lives, we should not think about cost. If it requires our energy, it requires our time, effort, commitment, we should do it.
Thank you, ma'am. Amrit, you have a question? Shukla, sir?
I have many questions. Shall I go ahead?
Yes.
Madam, there is a question from Sai Krishna. His question is, supposing someone calls on a suicide helpline and says, I am about to hang myself, and I just called to let you know.
Yeah.
So how should we go about handling those calls? Are those calls common?
Quite common. Why phone? Somebody has taken an overdose, come to our center and said, I would rather die here than die at home. Okay. So we talk to the person and tell him, look, you come, the fact that they have called and the fact that they are there means that they are still ambivalent. So we have to, it is a question of how we deal with them. If we suddenly say the decision, okay, I'm going to call 100, I'm going to call this person and somebody will come and take you, you are taking away the control for the person. They already feel they have no control in life and this is the only control they have. So you cannot abruptly snatch that away from them. At the same time, we have to make sure that we take responsibility to see that we are here to support him. We are not here to take away the responsibility. We understand what he is going through. But at the same time, we want to make him feel that there are other solutions rather than suicide. So what are the other solutions we can work with is what our aim is. So we have had cases like this, where actually he has taken an overdose of poison, came to the center and said, I would rather die here. And then after some time, we were able to cajole him and take him. By the time we did all the background activity and we were able to rush him to the hospital. Once I had somebody who called me from the beach. We didn't know where he was calling from. He called and said, I have taken, my parents are in Tirunelveli. I have left a message in my mobile. Please inform them that I love them. And then the line, the voice became feeble. Slowly we tried to ask him and ask him, he said, I am in the beach. Where about in the beach are you? I am near a statue. Then I said, see, you have called me. I'm going to come and search for you. Then he said, no, you can't find me. Doesn't matter. We'll try and find. So we put one caller on the phone and two of us got into the car and tried to drive around the thing and we found him near the, in the meantime, my volunteer was there and identified the statue. It's called the worker statue in the Marina Beach. And we found he was not there. Then we found there is a small subway which goes to cross to the other side. We found him there. And then we took him to the hospital, admitted him, and he had nobody. So that night, our volunteers took turns to stay with him. We called the parents because he had come from, there was some love failure. The parents came the next day. Now it's 3-4 years and every year, January 1st, he will come and give us sweets. He is happily married now.
Nice. Okay, man. Right. And there is another question.
Was it taken, Dr. Shukla?
Yeah.
The AIMS, that 2 psychiatric students admitted in the psychiatric ward of AIMS.
No, that has not been taken. No,
so
not
the
taken.
question is, we as psychiatrists have doctors who are admitted under us. We are treating them and we are not able to prevent suicide. So that puts a lot of question mark over, madam, everything. We know patient is suicidal. We know that the patient is our colleague. We know that the patient has been admitted under us. And then also we couldn't save 2 to 3 suicides. Maybe in the last 3 months we have seen in AIMS, the Premier Institute. So people have started asking that, what is our role there?
Yeah, see, the fact is, across the world, doctors have the highest suicide rate in terms of profession. And psychiatrists, anesthesiologists and veterinarians are the people who have the highest number of suicides. Veterinarians, we know the reason. The reason is that they are used to putting down animals. So putting down something is okay for them. Anesthesiologists, because they have ready access and they know the painless method, so they do it. Psychiatrists, there was a lot of questions why many psychiatrists die by suicide. And one theory was that you must be a little psychologically be vulnerable to choose this specialty. So you have become, you are suicidal. Or the practice of psychiatry burdens you for a long time. Actually, there was a very interesting study done in Boston where they assessed the personality of medical graduates when they joined, then when they finished, and then when they chose the specialty, and then at 20 years later. And they found that there was no major difference in personalities at the time of joining. But by the time when it came to choosing specialities, two distinct groups happened. One distinct group was the surgeons, and the other distinct group was the psychiatrists. The physicians were generally aggressive, risk-taking, impulsive, those kind of people. And people who chose psychiatry were more introverted, more introspective, more thinking, that kind of a personality. Then 20 years later, when they found the surgeons, they had the maximum number of substance abuse, and the psychiatrists had the maximum number of suicides. So they think actually when you join medical specialty, you're more or less the same. But you, to some extent, choosing the branch, you are probably think too much. And the fact that the profession itself has its own burden makes you more suicidal.
Madam, actually, I wanted to ask basically is that even if you know that you are having depression, even if you are under treatment, even if you have people to talk to, even if you know that people know that you are vulnerable and they're taking proper care of you, people might commit suicide. The very notion that if they would have talked or they would have been treated, their life would have been saved, puts a lot of guilt on many of the survivors of suicides, madam. The people have actually given their everything, they've tried their everything. Somewhere every suicide is not preventable, but some of them are. That's what basically the...
No, every suicide is not preventable, but majority are preventable.
Yes, madam.
Every suicide, we cannot say, see, we have instances of suicide happening in yearly, even there is, I believe, even a Neanderthal man where there is some hanging has something. So every suicide is not preventable. But fortunately for us, majority of it is preventable.
And we cannot predict which suicide is preventable.
Yes.
And someone has asked in the chat box, if you could elaborate on the research findings and your experience with high IQ being a risk factor for suicide.
Yeah. More than high IQ, it is majority of the people who have high IQ have low EQ. That is the problem. It is a combination of high IQ and low EQ which pushes them to suicide. If a person has high IQ and has good social skills, there is not much of suicide. But when the person has very high IQ and low EQ, then the combination is...
Can you please mute?
I can't hear it properly.
Yes, madam. Pawan, can you please mute others when madam is talking?
Sure, sir.
Madam, please go on.
There is another question in the chat box. At times, maybe asking a question about suicide in a patient who does not have any symptom of suicide will be implanting the suicidal ideation.
There is no evidence at all that asking the question precipitates or makes the person think about suicide. Enough research has been done in low-income countries, middle-income countries, and in high-income countries. It says that asking the question may give the idea to a person who is probably suicidal. There is no evidence at all. In fact, in the World Suicide Report, the first thing which we have written is, please, there is no evidence that asking the question induces that idea. Okay, so please ask. No research has shown that asking the question has induced the idea. On the other hand, majority of the people who are suicidal, see, suicide is a very strong emotion. Many of them are confused within themselves, okay? They don't want to verbalize. In fact, it is very difficult for a suicidal person to come and say, I am feeling suicidal. But when you ask them, are you feeling suicidal? It is easy for them to nod their head or say yes. Because it is such a strong emotion, even they have difficulty in understanding themselves. They don't. So it's easy for them to say yes. And that's why it's important to ask. In fact, for many people, it is a relief that you have asked. Because it's a relief that you have brought out in front what confusion is going on in their mind. And it also gives them an idea that you are open enough to talk about it.
Okay, madam. There is another question, madam. Interesting question. Are there any models for scaling up suicide prevention strategies as a public health measure? This is a question from Dr. Bibhu Kalyan Saab.
Yes, absolutely. See, we have 3 levels of intervention. That is universal intervention, selective intervention, and indicated intervention. Universal intervention is applicable to everybody. The 3 universal interventions which we recommend for reducing suicides are restriction of access to means. For example, in India, pesticide is a very, very common method of suicide in rural areas. So banning some toxic pesticide or reducing access to pesticide, like the project which we have done by putting a central storage of pesticides. We have done a study in Tamil Nadu where we have built like lockers, a central store where every farmer can keep their pesticide there. And we have shown in 10 years, those villages are absolutely no suicides at all. Okay. So reducing access, for example, or even for gun, for example, in US, states which have stricter gun controls have less suicides. Or for example, in UK, paracetamol poisoning came down drastically when the pack sizes were reduced from 100 tablets to 30 tablets. So reducing access to means is a public health thing. So if we can ban some of the pesticides, like we all know, like monocrotophos, chlorpyrifos, carbofuran, these are all the things which are used. So if we are able to ban them, which I think the government is planning to do because they have given a draft notification now, we hope pesticide suicides will come down. So reducing access to means is one public health initiative. The second public health initiative is reducing alcohol availability and consumption. Alcohol and suicides are 1/3 of suicides in our country happens under the influence of alcohol. Reducing alcohol availability and consumption has a huge role. For example, during the USSR, during the glasnost, when Gorbachev banned vodka and taxed vodka, 38% reduction in male suicides. Then the third public health strategy is regulation of media. We know sensational reporting of media leads to copycat suicide, and sensible reporting of suicides in media reduces suicides, and particularly celebrity suicides. We have so many copycat suicides from celebrity suicides. So these are all the public health interventions. Then we have...
Yeah, please, ma'am. Please, sorry, ma'am.
Yeah, go ahead.
No, please continue.
I wanted to know. Yeah, please complete your thought, ma'am. I interrupted.
Yeah, no, please ask. I mean, these are all the public health initiatives which we can do.
Okay, ma'am. In younger children, what would be the presentations, indicators? Suppose we talk to parents. So, what are the red flags, so as to say, in children and younger population?
As I said before, irritability, withdrawal, change in behavior, change in eating habits, change in sleeping habits, excess time on the internet, excess time on social networks, and any shame-inducing situations. These are all the red flags.
Thank you, ma'am.
There is a patient who comes to my clinic, madam. He or she expresses a strong desire to end his or her life. I have advised, I have given whatever medication I should give. I have given proper psychoeducation. I have told whatever I should. But then how can I, like I have got a phone call sometimes that is this patient yours? The police wants to talk to you. You know, these are very, very, you know, if you're in an institute, it's good. But if you are in a private practice, they're very, very dangerous signs for you. Because even your fellow psychiatrist will
Correct.
tell that his patient committed suicide. That's what we hear a lot of time. So how should we keep ourselves legally, in the right way if we have a
No,
suicidal?
if you have done your due diligence, you have to record everything properly. That's more in a private practice. Many of us do not keep. I'm also a private practitioner. Many of us do not keep a detailed case record. But for a person who's suicidal, it's very important that we keep a detailed record of every visit. And what is most important is every visit you have to do a suicide risk assessment and write down the risk. Okay, a strategy which you can kick off is the safety plan. For these kind of repeated chronic suicidal people, the safety plan has been found to be extremely useful. So it gives a sense of autonomy, it brings people together, and you are also there to help. Okay, you can give, you don't need to give your personal number, but you can give a number which can be called in emergency.
Madam, suppose the patient is here with you. Now you are the private practitioner. You have a single sheet of note with you. What all we should write in that maybe 10 minutes, 15 minutes after assessment, because we don't have too much of time in a busy OPD. So can
I told you it's just a 5-question assessment. Any previous attempt, any current suicidal ideas, do you have a plan? Do you have the method to carry it out? When do you carry it out? Who can help? This is enough.
That's all.
That's all.
Thank you so much.
Okay. Ma'am, any views regarding this armed forces? Dr. Yasser has asked about the suicides in armed forces. Any specific views on this?
Yes, of late there has been an increase in armed forces suicide, and some research has gone into that. What they found was that Navy and Air Force, the suicide rate is less, but the suicide rate is more in
So the internet डर गया कब से कोरोना हो गया
Hey, net problem, again net problem.
Amrit, there are loads and loads of questions. For how long shall we continue?
Another 10 minutes.
10 minutes.
Alim sir.
9:45 will end it.
Next.
Sir, as long as madam is available. जितना हमारे
No, let us continue up to 9:40 and we will close down at 9:45. The rest of the questions we shall ask them to mail.
Sir, there are also lots of requests for PPT.
No, I will announce it at the end because we are recording and we will share the recordings. One can have the PPTs out of that.
Actually,
Hi, Uttam.
Dr. Tumpati, madam were talking about some other
Hello.
audience is asking about the two levels of
two other levels,
selective and other residential levels. So kindly ask madam to.
Madam is.
She's offline now.
No, all of you can mark there is a recordings button that is on. That means it is being recorded with the consent of everyone. We will be sharing the recording with anybody who needs. There is no problem.
We will do a YouTube channel and we'll be putting all the videos.
Yeah, everything will be loaded, so you can get it there.
That maybe, but then as long till madam logs in next week.
I have logged in. Sorry. I'm sorry, really sorry for this.
No problem.
You have to speak for 15 minutes.
We have a bit of a wind at the rain.
People don't want to let you go.
This is internet's plan to give you some rest.
Much appreciated, but I feel bad I'm taking off your time. But there is some weather change in Tamil Nadu, Chennai now, so there's some lightning and thunder, and probably that's why this is becoming so bad.
So can I ask a question?
Yes, please.
So let us relate to suicide versus non-suicidal attempts. Suicidal attempts and non-suicidal attempts.
Yeah.
One of the basic difference is that in suicidal attempts, people want to get rid of pain.
Yeah.
And in the other group, they accept the pain.
Yeah.
They utilize the pain.
Yeah.
So is there any possibility of any biomarker like endorphin playing a role in that? And
there are a lot of biomarkers which are coming up now.
Yes, I wanted to ask that.
Yeah, there are a lot of biomarkers which are coming up. People are now talking about, so we have not yet reached the stage where the neurobiology is able to be transferred into biomarkers, except that we know that lowered serotonin has been associated with very impulsive, aggressive, violent suicide. In terms of biomarkers for NSSI, there are some initial work which is being done, but it is not, there was, how do I say, it is being very questioned very much. Because
there's so much confusion.
There is so much confusion. But what people are now focusing on is microRNAs. They feel that microRNAs have some role. And that can be used as a biomarker rather than all other studies.
I think Dr. Majid has a question. Majid sir, please unmute and ask.
Good evening, ma'am, and good evening, everybody. It was a lucid presentation. Lovely to watch and hear, ma'am, from you. Actually, what you said in the preventive protocols about media and copycat suicides, particularly celebrity suicides. For example, I am a reporter and I ask you, ma'am, that let us do a program today about suicides, and since there is lockdown for 6 months, suicides are going to increase because of unemployment, because there is a lot of issues right now all over the world and in India. So, ma'am, how would you respond to a media person once he tells you about what are the different causes of suicide and who are the people who are vulnerable? Because they really, the way they have sensationalized the recent actors' suicide, I think it's become very, very difficult. We have to run for our life from media personnel. Literally, I switch off my phone and I don't respond back. So how would you respond to a media person once they ask you about suicides and it is causes, effects, whatever?
So when a media person asks, use the opportunity to educate the media person about what exactly is suicide. And if you are able to convince the media person not to describe the method in detail, not to sensationalize it, but use the opportunity to provide help and provide, see, in the Press Council of India, we have a media guideline on suicide. Last September, we have worked with the Press Council, and the Press Council has come up with a guideline saying that no suicide story should be done where it is sensationalized, where the method is described in detail, photographs should not be given, the location should not be given. So the government has issued the guideline. The only thing is the media are not following it. So we need to work with the media. It is, and I don't think we should come away from the media. In fact, I think I have written something on IKP editorial about how psychiatrists can handle media. We should use this opportunity to educate people that suicide is not due to exam failure or having pimples in your face or fights. There are many, many reasons for suicides, and many of the reasons suicides are preventable, that they have to reach out for mental health support. You know, those are all the things which we need to emphasize to the media. But despite our best efforts, they will write whatever they want.
That is the point, madam. Actually, it was trashed and it was torn apart once that actor committed suicide, and the way media played it, it was really horrible. It was really, really very bad. So they normally sensationalize it for their TRPs. Even if you speak something, they will put it in such
Exactly,
a way that
exactly. That
it
happens.
really is
Yeah.
bad. So it is
So
very
we have
difficult
to
actually. Once you talk and they sensationalize the thing and they make a different turn out of it.
Yes. So what strategy I have been able to follow is to talk to the media and say this is what it is and keep on repeating it. So over the last of 3 to 4 years, I have been able to convince at least the media, the Hindu and the Times of India in Tamil Nadu, Chennai or southern state that whenever they write a story about suicide, they must give helpline of that particular state. So they do publish the various helplines available, and they don't give photographs. They don't reflect the method. So it is an ongoing process. Many developed countries, so many of my friends are appalled when they come and read the paper here. How can they write about suicide like this? So it is a process of evolution. Fortunately, we have a guideline. So my suggestion is, if you find somebody writing totally against the WHO guideline, write to the Press Council of India. I can share with you with the IPS the letter which he has written, where he says, please ask your members to write to me if the media is writing badly, and I will take action. So
one very brief input. The use of social media. So our social media behavior, can we, when will we have an app and a system that social media use, your phone use, could lead to us catching up the suicidal behavior? Is it possible that from my phone use, the phone is able to predict I'm getting suicidal?
See, there's a lot of work is going on. Actually, Google is doing a lot of work on that. There is a team which is sitting. In fact, quite a lot of people from NIH have gone to Google. Google has captured a lot of people from National Institute of Health, and they are trying to find out, because what happened is many of these people, suicidal people, post it on Facebook, post it on Instagram. So it creates a lot of followers and things like that. So they are building up a platform. There is something called as machine learning. I'm sure all of you know about machine learning. So machine learning has been able to predict, but then for machine learning to be effective, you have a good database. So if you don't have a good and complete database, machine learning is of no use. But people have been tracking the social media posts to find out who are likely to be at risk, and they pop up helpful messages, helpful sites, prevention sites, and so on. But the problem is those people who are searching. See, actually, if you go to Google or Facebook and put suicide or something like that, you will get suicide prevention lines and helpful suggestions. But the problem for us, we need, particularly is for the youngsters, is many of them go to the dark web where everything is available. Everything is available. They are coached, they pay money, they have suicide kits available in the dark web. I don't know how to get into the dark web, but all the kids know how to get into the dark web. And that is a major challenge which we have.
Thank you. Sir, what are the chairpersons to use? Should we continue, or should we wind up?
Thank you, madam.
Yes,
Thank you, madam.
chairpersons are the best persons to tell.
Yes.
Uttam, you had a question you can ask?
No, everything is explained by madam. Thank you very much, madam, for very lucid presentation.
No,
May I have a small proposal?
And
everyone visible is dangerous.
Madam
yes, please.
and
Yes, yes,
chairpersons.
please.
So in our regular practice, the clinic practice we do, there has to be some written guidelines on behalf of IPS. Why we need it. Whatever Madam has done, and most of us also mention about our treatment and purpose and our records. But that is not sufficient unless we have something to back it up. Because the opponent advocate, we are going to charge us with abatement of suicide. To tackle him, we must have something of the sort of guidelines of IPS, which they can show, yes, we have followed this. Guidelines of managing suicide in clinical setup. Towards that, IPS should take steps, and
Yes.
the leaders are there, they should work for that. This is my suggestion only, no question.
I think this can be done. And there is some task force on suicide prevention in IPS or not? Is it there? Hello?
Hello?
Am I audible?
It is there, sir. It is there,
Yes,
sir.
sir, you are.
So, is there any task force? Is there
Yes,
any
sir.
task force on suicide prevention
Yes,
in
sir.
IPS?
Yes, sir, it is there.
This will be complementary to question by Amri. There must be something which must not be elaborate, so that we can show, yes, we have done this, we are over.
Sir, madam, one last question I'll ask.
Yes, please.
Madam, how to manage conditions where a person has a very passive attitude towards their health issues that eventually causes death? Be it a cancer patient, be it somebody who is actively refusing treatment. We see a lot of people coming. So how do we manage such cases? That's a little out of, little different from that.
See, the people who have other chronic illnesses, HIV, cancer, so the most important thing is we have to, how do I say that? We have to ask the question and we have to treat the underlying condition and we have to inquire about suicide and do our risk assessment and do our treatment like anybody else. The fact is, we cannot say, oh, he's in terminal stage, so what can I do? It is natural to feel suicidal, Somehow we accept it. But actually, if you really look at it, let me give you an example. You've heard about the organization Dignitas in Switzerland, where you're allowed, it's where Switzerland allows euthanasia. So Dignitas is a place where people who want to die, who have terminal illness, they can go and admit themselves and they will have a painless death. Okay. So there are some countries, some states in some countries where euthanasia is allowed. Okay. The interesting research is people who go and get admitted in Dignitas, they have to be seen by 2 psychiatrists, and if there is any underlying pain condition or depression or psychological condition, they have to be treated. Only then the 2 psychiatrists have to certify they do not have any depression or anxiety or anything, and the oncologists have to certify that they have given the best possible pain reduction possible. Now, in this process, which takes about a month, 58% of the people, they get discharged and say, I don't want this, and go back. Even terminally ill people. Only 42% continue on.
Nice to hear, ma'am. Yeah. Ma'am, thank you so much. Thank you so much.
Question, Amrit?
Thank you very much. Now over to chairpersons.
Thank you, Dr. Tufan Pati, for giving us opportunity to chair this session, and thank you, madam, for giving a very lucid presentation on assessment of suicide and management of suicide. Really,
you can have your comments, Uttam and Dr. Vivek also.
Oh, thank you very much. So now
I should thank you, and I should thank you for your patience, particularly with my internet playing truant, for being so patient, and I'm sure you must have all had a busy day to listen to for all this.
But it was very much interesting to listen to you, madam, because every time we get something new from you.
Thank you very much. Thank you.
Thank you very much.
Thank you very much, Dr. Topan.
Thank you.
Thank you so much, ma'am. Thank you, everyone.
And thank you all audience.
Wonderful
also.
presentation, ma'am.
Sir, 2 minutes. Our state branch will be thanking everybody.
Dr. Vivek, some comment. Dr. Vivek Kirpekar over here.
He's in the meeting, extraordinary EC meeting that is going on.
Achha,
Okay. Would you like to add something, sir?
No.
Thank you.
Nothing from my side.
Dr. Devadatt?
So, closed? Meeting is closed?
No, sir. 2 more minutes. Our
Yes.
state will thank. State bank
Yes.
will.
Vote of thanks.
Okay.
Dr. Devadatta.
On behalf of
Subhendu, thank everybody. We'll close it.
Devadatta is not there?
We have
Yes, sir.
India.
Devadatta is there.
Okay.
So Devadatta, take over and then.
Sir.
No. Dr. Devadatta.
Yes, I have to summarize the.
You can speak.
Am I audible?
Yeah.
Yes. Yes.
I had to summarize. It was a great opportunity to listen to Dr. Lakshmi Vijay Kumar ma'am, who is the founder of Sneha, which is a premier institute for suicide prevention. Just I will highlight few points. At first, ma'am very nicely classified self-injurious behavior into non-suicidal and suicidal. Among the basic elements of suicide scenario, ma'am has pointed aggression as a basic element, which means wanting to leave or escape. Among the risk factors of schizophrenia, early recovery from schizophrenia, early relapse, higher in IQ, and high achievement before the onset of illness. Schizophrenics, those who are more complicated, are at more risk of developing schizophrenia. Among bipolar, mixed state is when patients are at mixed stage, then there is more risk of suicide. The warning signs we have to follow. We have to look for the warning signs. 80% of patients who commit suicide do communicate in their lifetime lifetime about suicide. Warning signs may be a verbal, behavioral, or psychiatric, like command hallucination, unstable or impulsive, aggressive, panic disorder, or global insomnia can be one cause of suicide. To read the mind of suicidal person, ma'am has very nicely pointed out what suicide may be of due to depression or anything, but the act of suicide is always an impulsive phenomenon. The person becomes ambivalent to recurrent suicidal ideas, perfectionism, or rumination, rigidity, and at last tunnel vision occurs. Then when to do the assessment. The initial assessment, initial first month of discharge, after discharge is very important when there is 60% chances of suicide. When there is an interpersonal loss or time of clinical worsening, recurrence and relapse, then assessment should be done. How to ask the critical question, ma'am has very nicely pointed out. The 5-question assessment should be there from. And then if there is prior suicide attempt, 30 to 40% of people who commit suicide have prior attempt in their lifetime. Coming to the management studies shows that CBT is basically helpful in the first 6 months, according to the Lancet. Lithium is most beneficial, and among the antidepressant, leaving aside sertraline, rest all other antidepressants are helpful. Clozapine is extremely helpful to reduce suicidality. Ketamine are also helpful to reduce acute suicidality. Intranasal S-ketamine is helpful. RTMS is also effective. Then ma'am has pointed out the third model of management of suicidal patients. In case of bipolar, in a question raised by some person, some doctor, ma'am has answered, in case of bipolar depression, low dose quetiapine and lurasidone as effective. In case of children with suicidal attempt, we have to look for the change in behavior, change in attempt, change in appetite, irritability, withdrawal, social withdrawal, and the communication is usually through social media, excessive time in internet or social games like this. So for the private psychiatrist, we have to keep a detailed record of the event, visit, that is most important. And I thank ma'am for the nice presentation. Next, Dr. Suvendu.
Thank you, Devata, for a wonderful summarization. I think madam will agree.
Okay, thank you, Devadatta.
Yeah, Dr. Subhendu.
Hello. Thank you, Devadatta, for wonderful summarizing the event. On behalf of Indian Psychiatric Society Odisha State Branch, I would say thank you, our Lakshmi Vijay Kumar ma'am, excellent elaboration regarding the suicidal assessment and suicide prevention. It was moderated by the chairman Vijay, Dr. Vivek Kripakar sir and Dr. Yusikar sir, and it was well moderated by our beloved Shukla sir, Amrit sir, and Dr. Alim Siddiqui boss. Thanks to our organizing chairman, Dr. Tufan Pati sir, every Thursday that using excellent job, and our organizing secretary, the dynamic Amrit Parjoshi and Alim Siddiqui. Thank you all, and thank long live IPS Odisha State Branch. Thank you.
Thank you. Next topic, sir. Next topic.
Couple therapy. Anisha Shah, madam from Nimans.
What is the topic?